and I'm delighted to be with the wonderful Ioannis Goutos. I hope I said your name correctly there, Ioannis.
Yes, that's fine, Kevin. So thanks very much for inviting me, and it's good to work with you again. Clearly, it's Rosacea Awareness Week, so I'm really looking forward to this event, and I hope that people will find this particularly useful.
Well, I know it's great to be working with you again. I know we've known each other for some time, and it's wonderful to have you here talking about rosacea. And I know I'm going to chip in a little bit and talk a little bit about particularly the Derma V. So perhaps we can kick off. Ioannis, tell us a little bit perhaps about your background.
Yes, so in terms of my background, I'm a clinical academic. So in my academic life, I'm a reader in scar management at Queen Mary University of London. I direct a postgraduate suite of courses focusing on aesthetic medicine. And in terms of my clinical practice, I'm now entirely private. So I work out of 152 and 55 Harley Street. And I'm also the clinical director of the London Scar Clinic.
Brilliant. Okay, and I say great to be here, and I'll let you start your presentation.
Fantastic. So this is just a little outline of what we're going to cover. So we're going to go over the basics of rosacea, how it presents, what we think causes it. We're going to skim over medical treatment and really hone on to laser treatment, and then specifically look at how the Derma V and its capabilities really fit in very well with rosacea treatment endpoints. And we'll also going to share some clinical results and clearly take some questions. So let's just kick off with the basics. So rosacea is actually a very, very common skin condition, and it has been estimated that it affects between 5 to 10% of the population globally. Despite quite a lot of earlier reports that really reported that it's a condition that mainly affects females, this has really been demolished now. And actually, I mean, in my clinical practice, I see as many males as females affected by rosacea and all the associated skin disorders. It is true that it's going to be more frequently diagnosed in fair-skinned individuals for obvious reasons. This does not mean that patients with pigmented skin cannot be affected. Effectively, rosacea is an inflammatory condition which affects the central face. It's characterized by recurrent flushing, visible blood vessels, some papules, pustules, but also a proportion of patients will present with phimosis changes. In other words, very thickened, sebaceous, some areas of sebaceous hypertrophy, very frequently over the nose, but also not too uncommonly over the cheeks. And also, very interestingly, a significant portion of patients will have eye manifestations. So, and this can range from mild, conjunctivitis, all the way to pretty sight-threatening degrees of inflammation within the eye.
Sorry, can I ask you a question there?
Yeah.
As well, just while you're on, you mentioned about the eye, and I know in the past, I mean, I don't know if we've used IPL in the past to be able to treat dry eye by treating above and below. Have you ever used the Derma V for that?
To be honest, I haven't. I know that there are quite a lot of different energy-based devices to treat dry eye, but it's interesting you mentioned that. So maybe I don't know if there is anything that Seriderm has got in the pipeline for that, but
yes, it's probably not for this discussion, but I was just, while you mentioned it, I thought, wow, I knew we used to do it in the past, but there's no reason why Derma V can't do that as well. Perhaps we'll connect afterwards and talk about an idea.
Yeah,
Sorry to interrupt you.
yeah, no, that's actually a good point. But there are quite a number of reports that have linked light and laser-based treatment of the skin with some improvements in terms of dry eyes and inflammation within the eye. But I have not actually done this myself, so I don't have any personal experience. But I have come across
Yeah,
manuscripts that really
I
talk
went on a
about
course.
that.
I went on a course years ago. We were using an IPL at the time, where you treat sort of under the eye and above, and it was work that took place in Russia many years ago, and it showed the improvement in dry eye. But I'm sure you're going to talk about the Dermovie with a microsecond 1064 and 532 pass. The similar thing would happen. It'd be something we could explore later.
Sure, absolutely. We'll talk a little bit about the classification, and actually, I think that can have some practical implications. So, throughout my training, I do remember just using the sort of more classical classification of erythrotelangiectatic, so those with redness and visible blood vessels, papular, those that come with pimples, effectively. The phimotus people will come with thickened areas of sebaceous skin, and those with eye manifestations. Just looking at the evolution through the dermatological literature, clearly, I'm not a dermatologist, but clearly just keeping up to date, there has been a revision of the classification, and effectively from the minute you have persistent erythema in the central facial area and phimotus changes, that pretty much really satisfies the diagnosis of cutaneous rosacea. And then if you look a little bit more in detail, there are some major and minor other criteria which involve stinging sensation, painful sensations, etc., etc. Now, what really causes rosacea? Again, quite a lot of different theories that have been proposed in the literature. At least 30 to 40% of patients will report a positive family history of those who present to clinic. There is quite a lot of consensus that a lot of the pathogenesis of rosacea relates to a dysregulation of the neurocutaneous mechanisms. And really, what we are really talking about here is that there are quite a lot of channels within the skin, receptors that get activated in response to a number of environmental stimuli, and they're responsible for vasodilatation, for the flushing that we see, and then degrees of inflammation associated with rosacea. The other limb to the pathogenesis is that there appears to be some dysregulation in the immune system, and there are quite a number of complicated pathways, including those involving toll-like receptors and the cathelicidin pathway, and also abundance of a particular population of CD4 cells. Another interesting aspect of the pathogenesis is the one that involves a mite, the Demodex follicularum. And essentially, quite a lot of studies have shown that patients with rosacea are overpopulated with this mite. And really, quite a lot of the approaches that we use, which we're going to cover a little bit later on, do try and target this particular over colonization. In terms of clinical practice, the majority of patients who will come for a laser treatment to a laser specialist, including myself, will have already had an established diagnosis by a dermatologist. So essentially, the most reasonable thing is to get those patients to identify their triggers and avoid them. Very commonly reported triggers include the sun, changes in environmental temperature, intensive exercise, alcohol, dairy products. A lot of those patients get specific advice regarding how to use appropriate skincare products in order to avoid excessive thermal and chemical irritation of the skin. In terms of medical treatments, again, the majority of patients will need to be under a combination of different approaches. So the first group is the alpha adrenergic and beta adrenergic agents, so things like brimonidine, propranolol, these target the flushing. Then there is another group, the like azelaic acid and ivermectin, that are really trying to target the pustules and papules. And then antibiotics actually have both an anti-microbial and also an anti-inflammatory action. So most patients are on a combination of those agents. Really, biologic agents like monoclonal antibodies, there are really quite a lot of studies going at the moment, and I think they might represent the future for treatment. A very common question that really comes up is, when we treat those patients with rosacea that are already on a combination of those agents, should they really discontinue their treatment? To be honest with you, what I have found is that that's not needed in the overwhelming majority of cases. And I know that quite a lot of dermatological colleagues advise that they just continue as they are, really. The only consideration is that if someone is on a photosensitive antibiotic, then we might need to be a little careful. We might need to change our fluencies a little bit, but I have not really had any issues performing rosacea laser treatments on someone with any of the standard medical treatment adjuncts. Let's just go into laser and light-based devices, which is really what we're here to discuss. So if we look at the literature when it comes to rosacea, the three currently most popular modalities are pulse dye laser, ND-YAG, and IPL. Just before we look at KTP and Derma-V, it would be quite interesting to review those three very commonly used modalities so that we can make some comparisons with the KTP. So the pulse dye laser has been around for many, many decades. There are quite a lot of studies which show that it is an effective modality. I think main limitations of the pulse dye laser is clearly there is a limited depth of penetration, and also it can really only target very, very small blood vessels. One of the big disadvantages of the pulse dye laser, and that depends whether you are on the purpuric or non-purpuric group. I personally am part of the purpuric group whenever I use PDL. It is actually purpura. And in some patients, that might lead to PIH, which, of course, needs to be managed. The other issue with a pulse dye laser, and I think, Kevin, you'll probably agree, is that the dye kit as a consumable, it has been an issue. And actually,
yeah, it is. We had major issues years ago where, I've been heavily involved in pulse dye lasers, and we had a major issue where nobody could get hold of the dye because it was a problem manufacturing it, and that became a real issue. I'm with you on purpura. I think some clients you need purpura, some obviously don't want that, and I think if you can offer both, then it's great, to have purpuric treatments and non-purpuric. Yeah. But yeah, it's the cost of the dye as well became a problem.
That's right, and I think this is where the Derma-V with the solid state medium, and we'll go over that, really provides a really good answer to those challenges associated with the pulse dye laser. When it comes to the ND-YAG, one of the real advantages of it is that it can penetrate much deeper and it can target more sizable blood vessels. And actually, quite a lot of patients with rosacea will have sizable enough vessels that would need an ND-YAG. The ND-YAG is actually quite a potent wavelength. So, and given the fact that actually, if you look at the absorption of hemoglobin at 1064, it's not as high as shorter wavelengths. It means that inevitably you're going to need to put more fluents. So, especially in experienced hands, there is a higher potential that you are going to cause scarring.
Yeah, I know that it was a big problem reported, when you start to use the NDAG, especially around the area here, and you're using an NDAG because the veins are a bit bigger, and then there were a lot of problems where people go in too high energy, spot size too small, spot size too big, and then creating indentations, so creating scarring.
Yeah, and I think the other thing to avoid, which I also found out throughout my training and my career, is that because you are using a small spot size, it's actually very easy to overlap. So you actually deliver huge amount of fluencies cumulatively, and then of course that you're swapping a vessel for a linear scar, which some individuals
it's not ideal. Okay.
It's not ideal. In terms of IPL, again, there are some studies in rosacea. The theoretical advantages are because you are essentially giving the skin a non-coherent band of light of different wavelengths. You can't target different depths. But I think in reality, again, IPL generally targets smaller blood vessels better.
Yeah.
And again, I think IPL needs quite a lot of care and experience.
You mentioned that. I know that people often think of an IPL as going to be, more straightforward compared to a laser, but actually, a laser is so much easier to use than an IPL. You have to be experienced to use an IPL.
Totally agree. Let's just now go into KTP, because clearly Derma V has got the KTP and the ND-YAG, the two different wavelengths. So, one of the really good things about the KTP is that it is, I think, fantastic for generalized erythema. It's fantastic for the superficial thin telangiectasia that you very frequently see in rosacea. It is very uncommon to get purpura. The patients that I am treating, that I have treated with rosacea, I haven't had a single one that developed purpura. And publications talk about swelling. My experience suggests that the swelling is very, very short-lived and very mild. So
typically, what would you say? Because I'm sure it'll come up as a question, is because that's often someone mentioned the other day. Said, "Oh, with KTP you get swelling," but my experience is just a few hours. But what's your experience on the swelling?
Whenever I ask my patients, some people will say the swelling lasted for a day, maximum two. Because I keep asking them, and actually most people report very, very minimal downtime. So I have not found, in my experience, and I've been using Dermav for over a year now, I have not found this to be an issue. And also I found a paper, it was the one that I've got on the slide, that did a sort of a split face comparison using PDL and KTP. And actually the degrees of clearance were very similar. KTP had more edema, but I really I don't find edema is a massive issue in my practice. Now, the latest article in the literature, and this is something that has been circulated via Seriderm actually over the last week, so everyone should have access to this, is a Spanish group that looked at Dermav, so a 532 and a 1064, in 25 patients, mostly females, mean age of 50. And essentially what they did, they treated the large visible telangiectasia with a 1064 with very standard parameters. And then for the finer blood vessels, they used the KTP, the 532 wavelength. And although there was some variability, the average number of passes was 2, which is consistent with what I do. So, for example, in a very typical rosacea patient, I will start off with an 8 millimeter spot size, 10 millisecond pulse duration, effluence around 10 joules per centimeter square on a sub-milli mode. And then with my second pass, I will go to 12 millimeter, 10 millisecond. I will drop my fluence a little bit, maybe 8 joules per centimeter square, and I go to sub-micro. And I think in that way, I am able to target different diameter vessels at slightly different depths within the skin.
And I know I'm going to cover the technical side in a bit of sub-milli, sub-micro, but do you think it's the ability to use sub-milli and sub-micro pulses that make a difference to the swelling? Because if you look at traditional past KTP lasers, they didn't have this. And I think, when you're using a raw 532 beam without sub-milli, sub-micro, I think there's a higher tendency of get swelling. So I think that's helped us reduce it. I don't know if that's your experience.
Yeah, I would totally agree with that. And when I first got the Derma V, I had to make the transition from PDL. And I did struggle with the sub-milli and sub-micro, but actually I'm I'm now much more comfortable with it, and I do feel that it makes quite a big difference. I do. But I think maybe what we need to do is we just need to get some more data, because it's a relatively new paradigm. But I
Yeah.
mean, my personal experience has been really positive with that, and I would
Yeah,
agree.
I agree with you. It's relatively new, and I think it's an exciting breakthrough to be able to do that, on both, and you can do it both on the 532 and the 1064. I think it makes a big difference.
Fantastic. So, Kevin, would you like to take over and just take us through some salient features of the Dermavi, and then let me know and I can move the slides for you.
Yeah, no problem. So thank you for that. And just for those, I'll just tell you a little bit about Dermavi. I've been in the industry a long time. It's over 35 years. And for me, I think treating vascular conditions is really exciting because you can treat a vein and then it disappears. You don't have to wait. You see the end point. And then all my years in the industry, I think this is probably the most exciting technology I've worked with. You get a fully high-powered 532 and 1064 laser in one with some incredible safety features and then some incredible features built in. And I'll talk you through some of them. Perhaps we go to the next slide. So there's two wavelengths, there's 532 and 1064, and I think Yanis has already covered about the two wavelengths when we look at vascular. But what's exciting with the wavelengths is you can also use 532 to treat pigmentation as well. So it's not part of this course today, but people can look online and you can see some brilliant results for pigmentation as well. So you've got a machine that's not just about vascular, it's for treating pigmentation as well. Plus, then you can also use it for other conditions, and so you can also use it for skin rejuvenation using this sub-microsecond pulse as well. So what's exciting about the technology, those who've used maybe a 532 in the past, the problem with the old generation 532 particularly, you had low energy, so you had really small spot sizes. But this is a much more powerful 532 and much more powerful 1064, which means you can have bigger spot sizes. bigger spot sizes, of course, allow you to treat faster, but more importantly, allow you to get better depths of penetration. So if I've got a hole of a vein, say on the nose, which sometimes can be difficult to treat, I need a big spot size to do it. So we can do that with 532 safely, because even with the big spot size, it's not going to go too deep. So in the past, people have struggled with that. So I think the fact that it's got such power built into it makes a big difference, allows you to get bigger spot sizes. Um, One of the things, and until I started to use this, I didn't really appreciate, and I didn't really appreciate the benefit of having an ICD cooling. And what's exciting about it, it allows you to adjust the exact amount of pre and post cooling. Whereas if in the past I've used them with maybe a cold tip or a cold blower, if I put the cold tip on for too long beforehand, the vein disappears. So it allows you to adjust the perfect amount of pre and post cooling. And that makes a huge difference to your clinical endpoint. It means I don't over-treat to begin, but it means I can do as significant post cooling. So if maybe you're treating a smaller vein, you'd have very little pre cooling, a lot of post cooling, and on something like a leg vein, you'd have a lot of pre and a lot of post cooling. It allows you to adjust it. I think that's a big advantage. And then the slide: why does pulse width matter? Pulse width matters because we have to match it to the size of the vessel. What's exciting about this machine is that you can use it like a normal laser, where you can adjust it from 0.3 milliseconds up to 100 milliseconds. But what it allows us to do is choose a pulse width and deliver it as individual millisecond pulses or microsecond pulses. That allows us to target different points. And so if we do you can use it at low energy at submicro to stimulate collagen activity, but we submilli and submicro, you can also use it then for treating smaller vessels, and using them together makes it ideal for treating things like rosacea. So the conventional technology in the past, I said the original 532, you could only adjust a a single pulse. You can alter the pulse to whatever you want, but it would be a single pulse. And then one of the breakthroughs on PDL, because they get a fast rise time and a short, like 1.5 millisecond, pulse up to 1.5 millisecond pulse, they allowed us to get better results on smaller veins and help for things like rosacea. So the great thing about Dermabee, we've been able to combine all the technology into one machine. So I think the next slide will probably show that. So it allows us then. So if you can imagine, you can have a single pulse. Say you can see the graphic there shows 5 millisecond, but I could choose sub-milli, and now what I can do, that 5 millisecond pulse becomes pulses at 1.5 millisecond each. So we can alter that, and you alter your pulse duration, and you said you use 10 milliseconds. So if you're in sub-milli, it'll make it up in millisecond pulses. That allows us to get less thermal impact on the tissue, which I think makes a significant difference on the swelling time. What's exciting is the submicro, is that you can deliver, say, a 5, 10 millisecond, whatever pulse you want, but now made up in 300 microsecond pulses, and that makes an incredible difference. So that allows us to target a whole host of conditions. I think you covered this already. So sub um, submicro we would use for really fine vessels, pigmentation, things like rosacea. Sub-milli we can use for medium vessels. And then when it becomes a really large vessel like a leg vein, we'll go on to a true long pulse. One of the thing is that, and I can remember seeing a video many years ago where Lutronic talked about, with all this power comes responsibility, and what they've really got at is bringing safety features into it. So one of the features they've been able to introduce is this temperature measurement system. So if the tissue is getting too hot, the machine will cut out and tell you it's getting too hot. So it's constantly monitoring the tissue. There's a technique we're not talking about in this lecture today, where you use submicro to stimulate fibroblast activity through heating of the tissue. And this allows you to get to the exact temperature. It's a great safety feature as well. So, the key features then on the system is you have the ideal wavelength. You have a choice of 1064 and 532. You have sufficient fluence. So you can have big spot sizes, with high energy. You can choose the exact pulse duration depending on the condition you want to treat. Then you've also got really effective skin cooling as well. Now, and then depending what you treat, I think we covered this already. We're using 532 for lighter skin types and superficial capillaries, and 1064 we can treat on all skin types, but for darker skin types as well. Okay. Just going to show a little video of the machine in use. Show the next one. So as Ioannis talked about, the first pass, you can see that was with a 1064 sub-milli. And now the second pass we do, and you can see the green flash, we change it to 532 and doing a second pass at 532. So you can mix them both together. You can deliver 1064, then 532. Is that something you routinely do?
Yeah, I do this quite a lot. And what I find is that, I mean, the 1064, sometimes there is really no choice. If you have, those perialar vessels, I mean, really, you need to use that. But on the cheeks, I have to say that I tend to stick to the 532 predominantly.
Yeah.
And they tend to do really, really well with the two passes. But in that latest paper, they did also mix the 1064. So I think it just needs to be tailored accordingly.
Are you mostly using sub-micro or sub-milli? Or do you combine them?
I combine them, sub-milli and then sub-micro.
So you do a first pass of sub-milli, then a second pass of sub-micro.
That's right. That's right. That's what I do.
Yeah. So, one of the features I didn't talk about, I don't know whether you even use this part of the machine. You can stick another sort of tip onto it, which has got a automatic rolling system. So when you move the handpiece, the machine will automatically fire for you. So rather than trying, if you try and do a fast treatment and think, okay, I need to move 1 or 2 pulses per second, as you move the handpiece, the machine will automatically track your movement, and that's quite useful. In fact, I don't know if you probably don't use it for this, but it's actually a very powerful YAG, and people do use this for hair removal and darker skin types because it's a really efficient, quick hair removal system as well. And I guess, do you want to talk us through some of the photographs there?
Yeah, so these are just some of the clinical endpoints. So we can see this lady does indeed have some pretty sizable blood vessels. I mean, look at those perialar ones and one on the cheek. So, 1064 would be, perfectly acceptable. And then if you see the blood vessels are less visible. So I'm pretty sure that was a 1064. These are not my personal pictures. And then you can see that's a very typical response that you get following 2 layers of KTP. So let's just look
we talked about the swelling, but that redness, how long does that redness last? And do you put anything to cool it down afterwards, or just leave it?
No, what I tend to do is I quite like the integrated cooling system within the Derma-V, but I also do some external cooling for people because I also have external cooling, and actually that helps quite a lot.
I think you're using like a Zimmer cooler, yeah?
Exactly, a Zimmer cooler, and then just use some aloe vera. And yes, they are the immediate reaction. Yes, there's quite a bit of redness, but again, it doesn't really last for long. So I would probably say a maximum 24 hours, really. Quite similar to what happens to edema.
Okay.
So some more really before and afters. So this is a clearly middle-aged gentleman, and you can see he's got some pretty impressive.
So can I, say on this one now, would you be looking at doing the background redness to begin, or would you say I'm actually going to go in and just treat some of those visible veins first, then bring it back, or do you do it all in one session?
Actually, with someone like this, what I would be tempted to do is start off with the 1064 ND YAG, let him settle, bring him back.
Yeah, I think I'd agree. I think you have to treat the bigger veins first of all, like, and then
there's really quite a lot of chromophore there, and I just think really, yeah. So that would be my my preference for this particular gentleman.
And can I go back to that next photograph again? Have you ever tried using the 3 by 10 millimeter tip?
Yeah, I absolutely love it. It's one of my favorite things. So
Because
just for those who are not familiar with the system, so what you get with a Derma V is a 3 by 10 millimeter spot size. So this is quite ideal in order to target, say, a perialar vessel that can fit within that spot size.
because something because I agree with something like this, you'd have to trace that out and try and do it. But if you go to 3 by 10, you can just hit it in one go, like, and that's exciting, like.
Yeah, the only thing that I would say from my experience is that if you're going to use the 3 by 10 in a slightly more extensive area, I really like to draw my rectangles, because
Okay, yeah,
actually it is quite easy to overlap with the 3 by 10.
yeah,
So you
I'd
need to
agree.
be really, really spot on.
Yeah.
But absolutely, I do like the 3 by 10, and I use it quite a lot. Um, I think this gentleman is probably a bit more, it's a common presentation, so that
Yeah.
just generalized redness, than someone with a slightly more visible vessels, and another one. And this one, I think this one is interesting. I am actually seeing quite a number of patients who have very, very generalized areas of rosacea. And there are some patients who have just cheeks affected, cheeks and chin, sometimes the forehead, not very commonly, and also the nose. So that's not really too uncommon. So yes,
To be honest, thanks for that. There are a couple of questions that come in.
Okay.
And I know we run out of time, but and people can send more questions in if they want, and we can answer them. But one of the question is, and I think it's covered on the photographs, but how typically when you client come in, I know it's typical. How many sessions do you say to them?
Uh, that, that's a really good question. I think, what I really tell them clearly. Uh, all of my patients will have seen a dermatologist, so they will have had a really good session on the nature of the disease. It's a chronic condition. What we're trying is to manage it. I always tell my patients, most people would need a short course of 3 as a minimum. And then based on their response, you can take a break for treatment. And if you find that your rosacea is controlled with your medical treatment, absolutely fantastic. I also tell them that because it's a chronic condition, they may require some maintenance sessions in the future. So I think it's important that we don't tell patients, what, you're going to have 2 treatments and you can say goodbye to your rosacea. But my experience suggests that after 2 or 3 sessions, most patients will see a very significant improvement in the appearance of their skin condition, and this is how I talk to patients about laser treatment and rosacea.
And I think you covered this one as well, but someone's put a question in. Do you use it in combination with any other treatments, maybe drugs or cosmeceuticals?
So I mean, one of the really common things that I do, I will, especially if someone has phymatous changes, then I will use a carbon dioxide ablation. I don't actually currently use any topicals. in combination with laser treatments, and I don't think I have found very much in the literature when it comes to laser and light-based devices and topical. So it's not something that I'm sort of aware of.
I'm a laser guy, and I just believe the laser can do it on its own. But um, the other one was, do you use it to treat other conditions, and if so, what other conditions you do? And then another question is, have you ever used it, and can you use it on leg veins?
Yes, absolutely. But I think with leg veins, you're going to need to get onto your NDAG. And the other important thing is that, when you're treating leg veins, the overwhelming majority of cases, I will send my patients to have a full venous assessment, because, quite commonly, if you are going to treat a couple of veins without treating the underlying cause or any incompetencies in much bigger veins, then they're very likely to come back. So absolutely, yes, I have some experience with the derma and leg veins. Absolutely.
I think a little plug for my course. They should come on my level 5 vascular course. I'm not sure if there's any other questions. I think one of them was about I think one I think I can answer, but you can chip in. It was, how do you change it? Is it easy to change the spot size? Well, they're different cartridges. To me, it seems straightforward, but you're a practitioner. I don't know if you've ever had a problem changing it.
No, not at all. I haven't had any particular issues with that. And actually, quite a lot of the handpiece ends can give you, 3 different wavelengths, so 3 different, spot sizes like 8, 10, 12. So when I treat rosacea, I don't actually need to change the physical handpiece end. So not really, no issues with that at all.
And have you ever used the it comes with a fractionated tip. Have you ever used the fractionated tip?
Actually, no, I haven't.
No, I've never used it. I've never seen it used, but it comes with a fractionated tip where you can fractionate the 1064 and the
Yeah.
532. I think the idea is it allows you to treat, if you're using 532, get to better depths for treating pigmentation, and it helps with some scarring when you do it on 1064. But you're using, I guess, a CO2 laser for scars. Yeah.
Yes, I mean, I really use the CO2 quite a lot. So, if you look at my practice, the combination of Dermav and CO2 is probably the most common combination. Absolutely.
Yeah. So I think that's it. I don't think there are any other questions. By all means, people, please send us the questions and we'll answer them. I know there's a follow-up webinar after this where we're going to be talking about other applications of Dermav as well. So look out for that. And then if you get any other questions, I can pass them on to Ioannis, and
Awesome.
we'll answer the questions too. So thank you very much for today.
You're very welcome.
And I will see you again soon. Yeah.
Fantastic. Thank you very much.
Cheers. Thank you.
Bye bye.